Well, hello and welcome once more to our BSHAA Webinar series. I'm Raul Garcia. I'm a BSHAA Council member, a consultant audiologist and owner of the Audiology Clinic, a private practice in London. Today, we have Dr. Brian Taylor join us from the US. Dr. Taylor has 27 years of clinical teaching and management experience, and he's the clinical director of audiology for the Fuel Medical Group. He's also editor-in-chief of the Hearing Healthcare and Technology Matter blog, and an invalid contributor to on audiology online courses. Today, we're here to talk about maximizing patient outcomes in the era of consumer-driven healthcare. You can all ask questions during the presentation, and I will collect them and I will endeavor to ask those at the end. Without further ado, I'm going to pass the microphone over to Dr. Taylor. All yours.
Okay, thank you very much. I'm happy to join you all. I hope you can hear me and you can see me. I can't see you, and so I hope you can see me. I'm dialing in from Minnesota, a beautiful summer day here, and I'm happy to spend the next hour and a half or so with you. We'll go ahead and get started. Let me see if I can advance the slide. There's the title of my presentation, Maximizing Patient-Centered Care or Outcomes in a Consumer-Driven Healthcare System. And just very briefly about my background, thank you for the nice introduction. I am the Director of Clinical Audiology for a consulting group here in the United States called Fuel Medical. We work primarily with ear, nose, and throat practices that have audiology clinics within them, helping them improve efficiency and outcomes. And some of the things we talk about today are what I spend my day doing with Fuel. I'm also the editor of a couple of different publications, one online, the Hearing Healthcare and Technology Matters blog. Hopefully you're all aware of that. We pride ourselves on being an independent source of industry news, and I hope you all subscribe to our weekly newsletter. And I'm also the editor of a publication by the name of Audiology Practices. If you're a member of the Academy of Doctors of Audiology, that's a publication you can receive. I also believe you can find that online. And I'm going to go ahead and get started. One of the main points that I want to make right out of the gate this afternoon is that patients have become consumers in a lot of different ways. And the way to illustrate that point is to think back 30 years ago. For me, 30 years ago, I was in college at a university in Wisconsin. And in 1988, if you were had a symptom, if you had a concern about your health, and you wanted to get some information on your own in a self-directed kind of a way, you had very limited cumbersome options. You had to go to the library and go to the card catalog. I don't know if you call it this in the UK. We call it the Dewey Decimal System, and you'd have to weed your way through lots of printed material to get an answer, and that would probably take days or maybe even weeks to get all the information that you need, let alone try to read through it. And of course, today, you can do that with Google online, or you could even ask your smart speaker to give you some information without even printing the material out. And what that means is people have access to a tremendous amount of information. And as you probably see in your practices, they come to you armed with a lot of information, some of it misleading. But it profoundly changes the way people interact with their healthcare professional. Rather than being paternalistic and relying on the healthcare professional to give them all their information, they can get a lot of that information on their own, and they can actively participate in the entire process. And as I said, that dramatically changes the way we do things with our patients. Because as I mentioned, patients historically lack that information, and now they have access to it, and in profound ways they can self-direct their own health care. The other thing I wanted to talk about early on in my presentation is audiologists and just in general hearing care professionals. It doesn't matter what your title is or even what your background is, but if you're working with adults that have age-related hearing loss, I think you have one of the most challenging jobs in all the healthcare. And that is because unlike many other professions, you have to juggle both the medical and the chronic care model of disease. And without spending too much time on this point, but it's worth emphasizing that really one of the first things any hearing care professional has to do is rule out a serious, non-benign medical condition, like an acoustic neuroma as one example. And in order to do that, you have to be accurate and precise in your testing, because of course you don't want to miss a catastrophic condition that a person may have. And once you've ruled that out, then you can go ahead and you can treat that person usually with hearing aids. But my point is that the medical model, which requires accuracy and precision, requires a different set of skills compared to the chronic care model, where you're helping somebody through the active process of acknowledging and taking action around a condition like sensorineural hearing loss. So I think those points will sort of illustrate themselves as we go through the material. But really the main objective, or my main points today, are that self-fitting hearing aids, sometimes called over-the-counter hearing aids, are going to, I think, in a big way, change the way that we practice audiology. And the second point I want to make is that patient-centered care, which some of us call counseling, is something that's not only valued by adults with hearing loss, but it's also something that can't be duplicated with computer algorithms, machine learning, or artificial intelligence. It's a very human skill that requires the expertise, the empathy, and the knowledge of somebody like yourself. And that's a fee-for-service opportunity that sometimes is overlooked. So my goal today, because I'm a clinician myself, and I like to try to provide as much practical information as I can, is to provide you with some different counseling tools that you can use that not only help you, I think, do a better job with your patients, create better outcomes, but there are also some tools that will, I think, allow you to charge a fee for a service that stands alone from the delivery of hearing aids. But it can, in addition to that, help you efficiently dispense more hearing aids, as we'll talk about. So let's start this journey over the next hour and a half or so with a question. And the question is this: what happens when we interact with an adult that has hearing loss? I want you to think about that for a moment. What happens during that interaction? And I want you to think about it from the point of view of the patient, who oftentimes has been dealing with or coping with this hearing loss for a number of years. Because if you look at the research in this area, most of us probably would answer this question. I'll go back to the question, what happens when we interact with an adult with hearing loss? Most of us would answer the question differently than what happens in reality, at least based on some research in this area. Because what the research in this area shows is very quickly, audiologists and hearing instrument specialists have a tendency to overload patients with too much information, that we focus maybe too much of our time on a detailed analysis of the test results. We focus too much of our time on the technical features of hearing aids. And when you ask patients what happens during that encounter, they provide you with some, I think, really important information that we should pay attention to. And that is, they have a tendency to say that audiologists engage in what's called audiogram-centered behavior, where we want to control the interaction by talking about and showing the patient how much we know about the ins and outs of the audiogram. So there's a series of studies that have come from Australia. I've cited one of them here, but there's many more than this, which essentially say that the audiologists deflect all all potential interactions around the emotional aspects of hearing loss. We have a tendency to deflect that and get right into talk about the audiogram and technological options. And that leads to what some other researchers, Karen Munoz at the Utah State University, has done some important work in this area, which essentially says we move from audiogram-centered behavior into product-centered talk or behavior, where we, as I said, deflect these emotionally laden topics and focus too much of our attention on technology, because that's kind of our comfort zone as professionals. And when we do that, it's a lost opportunity to talk about something that really, I think, patients want us to address, which is the emotional and the social impact of their hearing loss. So when we talk about counseling today, which is a major tenet of patient-centered care, we could really be talking about two different things. One is informational counseling, and the other is personal adjustment counseling. And the takeaway here is that the real value of what an audiologist brings to the table is your ability to be good at personal adjustment counseling. And that is, as we'll talk about, addressing the emotional and the social impact of a person's inability to communicate. And what audiologists typically engage in, which is not all that meaningful to the patient, is informational counseling. Informational counseling is anything when you talk about the audiogram, when you talk about hearing aids, when you talk about when you talk about features and benefits, that's conveying information. And yes, that's important, but it doesn't get at the root cause of what may bring a patient into the office and how you might be able to help them over the long haul. And so your ability to engage in personal adjustment counseling really can have an impact on that patient. And by the way, as a sidebar, informational counseling is what is often in a hearing aid instruction book. That type of counseling could be replaced with a YouTube video, with a lesser credentialed audiology technician, even with printed material. And personal adjustment counseling is something that really can't be duplicated, but besides anybody that has advanced training. So my definition of personal adjustment counseling, which I've already kind of talked about, but my sort of formal definition of it is on this slide right here. It's your ability to address the internal challenges and barriers that are associated with hearing loss that are experienced not only by the patient, but also their communication partners. And ultimately, it's our ability as a good counselor to help those patients become effective self-managers of their condition. Self-manager being their ability to cope, their ability to problem solve when they get into a noisy situation so that they can become an independent self-manager of their hearing loss. So far, just sort of kind of recap what we've talked about over the first 15 minutes. Audiology, right now we focus too much on talking about, we look too much through the lens of the medical model, looking at technology, looking at hearing aid solutions as sort of the end-all be-all. But as we're going to talk about, that's not a very effective way to conduct business. I want to talk about how we got there. So we're going to talk about the convergence of three forces that have are forcing us to change the way that we practice in our clinics. And those three forces are here on this next slide. They are demographics, the aging baby boomer population really around the world. Another force or another factor are comorbidities that are associated with hearing loss and some of the public health issues surrounding them. And then finally, just innovations in technology. It's really the convergence of these three forces that are forcing this change in the way that we practice, taking the focus off of a technological solution and putting it more on a patient-centered counseling solution. So let's just look a little bit in detail on each of these three forces. The first, as I mentioned, is changes in technology. As we know, technology is always incrementally improving. But what's really interesting over the last year or so, and I think it will happen more quickly as we move into the future, is that what you can do in your own clinic with a HiPro box, with NOAA, with fitting software, with a PC, can be done with a smartphone, an app, machine learning, and a self-fitting device. So devices that had to be programmed, fine-tuned, and adjusted by a professional, a lot of that capability is now in the hands of the consumer that has broadband internet access and a smartphone. And we'll talk in more detail about that in a little bit. The second factor is related to some of these comorbidities that are linked to age-related hearing loss and how that has quickly become a public health factor. So I think, as all of you know, there are many chronic conditions. You see them listed here on the slide, everything from cognitive decline to the increased likelihood of falling, to isolation and loneliness, common conditions in older adults that are associated with sensory neural hearing loss. And you can read the ins and outs of this by downloading the material that you see cited on the right side of the slide that was published a couple years ago by this American group called the National Academy of Science, Engineering, and Medicine. If you want to learn, or if you want to get a summary of these associated factors, I would encourage you to download that material. Because what it really tells us is that the condition is growing. This relationship between hearing loss and these other comorbid factors is definitely there. And even in the face of that, only about 1 in 5 adults that have a hearing loss actually own hearing aids. And it's because of the factors that you see listed on the slide, some combination of cost, stigma, and access. And the report goes into some details around why. That brings me to the third factor I mentioned, and that is demographics. In the US, we know that 10,000 individuals each day are turning 65. The UK, the numbers are probably similar per capita. We call that the baby boomer bump or the age wave as depicted there on the graph. And really what that means is that in addition to the sheer number of aging baby boomers kind of shifting the way healthcare is delivered, it's really because of how they've grown up in the modern healthcare system that's changed their behavior. When you think about it, it's kind of astounding. People born after about 1945 are really the first people on Earth that have grown up under the umbrella of modern medicine, with vaccinations, with clean water, with antibiotics. And that's kind of changed their outlook with respect to how they interact in the healthcare system. They kind of have a bulletproof mentality, as you probably see in your own clinics. People born after 1945 expect to live a long life relative to people born before that. I think my second bullet point there kind of tells the story. Life expectancy between 1900 and 1999 is improved by 30 years, and that undoubtedly has had an impact on people's behavior and expectations regarding healthcare. So I think that's an important topic, I think, to kind of wrap your head around. Okay, what I want to do next is go back to my main point and spend a little bit more time talking about over-the-counter self-fitting hearing aids and how I think they have the potential to allow more people to self-direct their care. So there's been a lot of talk about over-the-counter products, but I think the big change here is around self-directed care and self-fitting hearing aids. And I think we have to make the assumption We don't know how many people it is, but some percentage of individuals out there that are coping with age-related hearing loss are going to be able to successfully self-direct their care if given proper tools. And they're going to be able to purchase a hearing aid over the counter. They're going to be able to download an app onto their smartphone that will help them learn how to use that product. It will help them program it and adjust it and train it to their preferred settings. And they'll be able to do all of that successfully without ever seeing an audiologist. By that same token, there's probably going to be a certain number of individuals out there that choose to go this route, but it turns out to be an utter disaster, and then they have to figure out how do they take care of the mess that they've created. Is there an audiologist out there that can help them navigate the successful use of the product that they've maybe bought over the counter, and now they need to figure out how to use it? So this is a pretty important, I think, an assumption to make. We don't know how many individuals fall into this category, but my guess is it's more than 1 or 2%. Likely it's over 10%. So there is going to be a group of people out there that will be able to navigate the entire self-fitting process. And what I mean by navigating the entire self-fitting process is really at the top of this schematic. They'll be able, with a high quality regulated product, they'll be able to conduct threshold measurements of their hearing through the device. That device will be able to prescribe the proper gain settings based on that information. And then the patient will be able to fine-tune or train or personalize the gain settings based on their own preferences. Those devices are actually available today, and it's really a incremental improvement over the last 20 years of digital products that have gotten us to this point. And that's kind of what this slide illustrates. This didn't happen overnight, that we've kind of naturally, incrementally gotten to this stage through technological innovations. Which brings me to, I think, an important part of this webinar, which is maybe demystifying what all of these different names, different terminology that's thrown around, what they all mean, and how they can be defined. What's the difference between a hearing aid? In this slide, you see a smartphone-enabled hearing aid. What's the difference between that and what we call a PSAP, a personal sound amplification products, which have been around for many years? It was only around 2010 that you started to hear more and more about them. And what's the difference between a PSAP, a hearing aid, and this new term, OTC, or over-the-counter hearing aid? Here's an example of, it's still called a PSAP, but Bose, which is a very well-respected consumer electronic brand, has this product called a Hearphone, which in the United States is labeled a PSAP at this moment. But if the regulations in the US change, this is one of the types of products that could be relabeled a over-the-counter hearing aid. And what's the difference between an over-the-counter hearing aid and a self-fitting hearing aid, which is this product in Australia, Blamey Saunders Hears, that's been around now for a year or two. How does that differ from some of these other terms that we've thrown around? So let's start with self-fitting hearing aid. Self-fitting hearing aid, as I mentioned already, is a product that a person could fit themselves from start to finish, testing, gain settings, gain preference changes, all done by the person on their own using their smartphone and an app. And as I mentioned, there's already a handful of these devices on the market today. The important point I want to make here is that this product could be sold over the counter direct to consumers, but it also could be sold by a licensed professional. So imagine you work in a situation where you've determined that a person could self-direct their care. You found through your testing and through your assessment process that the person could do this with a high degree of probability successfully. You could be in a world in the next few years where you would offer this device to the person here and just essentially say, we've learned that you can probably do this successfully. Here's the product. Have at it. You could dispense that product probably at a lesser price point. You would see the patient back less often for care and follow-up services. And I think it's more efficient for you from a business standpoint, and from the patient standpoint, they don't have to see you as much, they're paying less. So in a lot of ways, once you've determined who those patients are, this could be a successful model for some percentage of patients out there. So anyway, just to kind of go back to that question, what's in a name? You know, we have hearing aids in the U.S. Those are regulated by the FDA, and they have to be sold through the professional channel. They have to be, the product claims have to be substantiated with some amount of research. PSAPs are largely unregulated, and as you all know, in an unregulated market, the quality can vary substantially. So patients never know what they're getting if a product is unregulated. And then we have this new category of OTC or self-fitting, which don't officially exist yet, at least in the United States, as an official regulated product. But in a lot of places around the world, they're already being sold. So the question really is, are they effective? But in addition to those three product categories, what makes it even more challenging for us out there in the clinics are that technical innovations have brought a lot of other non-custom products into existence that actually can be quite beneficial to our patients. So we have these headset amplifiers that have been sold primarily to be used with the television, but they could be used, we call them pocket talkers in the US. They could be used in one-on-one conversation between a hearing impaired individual and another person. And as I've already mentioned, we have all these personal sound amplification products known as PSAPs. And just within this broad product category, there are many different distinct types. There's hearing aid knockoffs, which are essentially defeatured hearing aids. There are cordless multitaskers that, in addition to providing amplification, these kind of products, which look sort of like wireless earbuds, which are becoming more and more common, allow people to stream music off their cell phone. They allow people to talk hands-free on their phone. They allow for biometrics. You can measure heart rate, number of steps, things like that. And then we have this third category of PSAPs, which do the same thing, but they have a yoke that goes around the neck that allows a person to use it and not worry about having to lose it or fall out of their ear. So just within the PSAP subcategory, you have three different types. And then finally, we have another subcategory of amplifiers that you can download and essentially turn your phone into some type of an amplification device. Fenix, Petrolex, you see here on the slide, are amplification apps. Tunity, which allows you to stream audio from a television through your smartphone into earbuds, is another. Sonic Cloud is a way to customize audio from a smartphone. So there are a lot of different apps, and what I want to do next is kind of reflect on this question: are PSAPs and self-fitting hearing aids effective? And I'm going to pause for just a moment for us to reflect on that.
Thanks, Ren. Okay, everybody. So, yeah, an important question. One that creates a lot of controversy, I think, around the world. One that creates perhaps fear, some of us, but is embraced by some others. So you've got any questions or any comments to make, please don't hesitate to make those
Yeah. So
in
now that I'm
the
back on
question
the
box.
air, I'm taking care of my doorbell rang, but that's taken care of. So yeah, we covered a lot of information so far around these different type of non-custom amplifiers. So if anybody has any questions about those, maybe we can save them to the end. And I just want to make the point that a couple different points, and one is because a lot of these products are unregulated, the quality is highly uneven. And I use what I call the cheap beer analogy, which is there are a lot of really cheap beers out there, and most of them taste like swill. But every once in a while, you might run into one that tastes kind of good. And it's kind of the same world with respect to non-custom amplifiers. There are a lot of really low quality ones out there that are pretty bad, but every once in a while you run into one that actually is fairly comparable to a conventional hearing aid. So we're going to talk about that next, and that's going to lead into a discussion of who might be a candidate for some of these products. So let's do that next. What I'm going to show you is basically to answer the question of which non-custom amplifiers are of high quality, rather than rely on anecdotes from other clinicians or from even your patients. It's always good to look at what the published research says. And here is one, I think, really important study to know about. This was published in the Journal of the American Medical Association about a year ago. It comes from the group at Johns Hopkins University in Baltimore, and an audiologist by the name of Nick Reed is the lead author. And what he did was he evaluated several non-custom amplifiers in relation to a conventional hearing aid. And he did this using a speech and noise task in the sound field. And what you'll notice on this slide is the cost of each of the products. Obviously, the conventional hearing aid costs quite a bit more than the PSAPs that you see listed. Then you see the mean score on the speech and noise task. I believe it was at a +5 signal to noise ratio at a relatively low intensity level, trying to mimic sort of a typical speech and noise scenario. And you can see those scores relative to the unaided condition. And keep in mind, these were older adults that had a mild to moderate high frequency hearing loss. Then you can see the percent of improvement. And then you can see on a cost basis, the improvement for every 1% of speech intelligibility and noise improvement. And what you notice there are that a few of the sound amplifiers are pretty comparable to the conventional hearing aid. You see the Sound World Solutions product and the SoundHawk were only about 1 or 2 percentage points off of the hearing aid. The product from Etymotic Research was about 8, so 3% different. The Tweak Focus was about 5, so maybe about half of the better sounding products. And then you see one there, which was only was the $30 amplifier, actually made things worse. So what's good about this study is it kind of shows you for one typical speech and noise scenario, some products provide comparable benefit relative to a conventional hearing aid. One product actually makes it worse. And it tells you that if a person's spending around $300 American dollars, that they may get a product that for at least one typical scenario is giving them some measure of improvement. So price might be somewhat of a proxy. So that's one study I think it's important to know about. And if somebody wanted that study, they could find it online, or I could send it to them if they wanted it. The second study looked at one particular product that bills itself as a self-fitting hearing aid, and that's the Sound World Solution product, which retails for just under $500 American dollars. And this was a study that was published earlier this year in an open access journal called Trends in Hearing. So any of you could find this journal online and look at this study for the details. But they asked a very simple, important question in the study, which is, do self-fitting hearing aids produce results that are similar to conventional devices? And they designed this study using a combination of experienced and new users, and they took 38. They found that 38 people could kind of go through the process with very little help or really no help from a professional, and they compared their results to 14 individuals who went through what they called the clinician-driven, kind of the typical process that we all use today. And for those that were experienced users, they were able to compare their user-driven fitting to their conventional conventional fitting. And long story short, after 12 weeks of use, they found that the results were pretty similar for both the clinician and the user-driven fitting. That after correcting for cognitive decline and degree of hearing loss, that the outcomes were similar. Now, the thing to keep in mind about this study, before you get too excited about it, the outcome, or too worried about the outcome, is it didn't completely mimic an over-the-counter model where a person could just indiscriminately buy something off the shelf. At the beginning of the study, they determined the patients that could kind of navigate the self-fitting process, and they put them into one group, and they compared them to the group that weren't able to do that. They had to go through the clinician route. So it was kind of an artificial way to put people into the two different categories, and it didn't really mimic what would happen in the real world. But it does show you that for patients that kind of qualify for the over-the-counter model, they were able to do that as successfully as somebody that went through the traditional clinician-driven approach. So that shows you that this model can work for the right candidate. And what's also interesting is, if we go back a couple slides, the product that they used is this one. Now, you can't really tell from just looking at this photo, but that's a pretty cosmetically unappealing hearing aid. It looks like about a 1985 BTE. It's a pretty big receiver in the canal product, not very cosmetically appealing. And you have to imagine, as the products become smaller and as self-fitting technology as it continues to evolve and becomes easier to use, more and more patients can probably, once they're properly self-identified, could probably successfully use that product. But this is a good study to pay attention to, because it does show you that there are a group of people out there that once properly identified, a self-fitting hearing aid can lead to a successful outcome. But I think one important question does remain for those patients that do self-fit. What happens when somebody has difficulty using one of these products because if they have feedback, if their ear is sore, if they have poor performance? Is there a mechanism in place that will trigger them to see an audiologist if they have problems with one of those areas? So those are some questions that still remain largely unanswered. Anyway, some things we can talk about maybe during the discussion phase. What I wanted to address next is who might be a candidate for non-custom amplification devices. Imagine a world. You don't have to imagine the world. We live in a world where only about 20% of adults that have a hearing loss own hearing aids. So there's a lot of opportunities, I think, to expand access to amplification by using one of those, or by recommending one of those non-custom devices that we've talked about. And I just wanted to kind of mention this briefly and not go into too much detail, but I think there are at least 4 different groups out there of patients that underutilize traditional hearing aids that could benefit from some of these technologies that we've talked about. And you see those groups listed on the slide. One group are the older old. Those are patients that are over the age of 85 typically. Another group would be patients that are, I would call, technology overshoots. And then we have contemplators and patients with cochlear distortion issues. I'll give you a little bit more detail about the first three and just briefly mention that group number 4, those are patients that typically do very poorly on word recognition tests. They, even at a loud but okay level where you're establishing PB max, those are patients that get a score of maybe say less than 40%. And even the very best hearing aid can't overcome the effects of cochlear distortion. And the argument is maybe patients that have that high level of cochlear distortion would do just as well with a device with minimal technology at a lower price point. But remember, those other 3 categories, for example, older olds, patients chronologically over the age of 85, they're prone to physical dexterity problems. They can't get the hearing aids in their ear. They're prone to cognitive decline issues where they may lose the hearing aids. They're susceptible to social isolation. A very low number of these patients own hearing aids, even though a very high number have hearing loss. And remember that banded non-custom multitasker headset, something like the Bose Hearphone, that form factor might be a really good solution for somebody that's prone to the problems you see listed here on the slide. Technology overshoots, another subcategory of people that could benefit from these non-custom self-fitting solutions. These are typically patients that don't want any part of a hearing aid because they're younger, there's a stigmatizing effect, and they may only have issues with their hearing in 1 or 2 very challenging listening situations. And they want a device that allows them to multitask. They can use it in a restaurant, they can use it in a pub, but they can also use it to stream music and to talk on the phone hands-free. And then we have this other group of patients, which I call contemplators, which are, if you look at their audiogram, they are hearing aid candidates, but they are what we call frustrated copers. Because of the stigma associated with hearing aid use, they're really not ready to jump in and start using conventional hearing aids. And these non-custom products that could be self-fitting, that sometimes don't look like hearing aids, might be a way to lower the stigma and encourage the patient to kind of dabble in a low-risk way with amplification from the comforts of home. So I believe there are a lot of patients out there, maybe 30%, maybe 40%, maybe more, that are in that, if you look at the bottom of this slide, in the pre-contemplation or the contemplation stage of change, that are essentially ambivalent or maybe even unaware of the problem, but if given the opportunity to use something from the comforts of home that's self-fitting, might jump in and start dabbling with amplification and move to the action stage a lot sooner. Now, we don't really have time to get into the stages of change model. I just want to kind of suffice it to say that there are a lot of patients that come into your clinic that are in the contemplation stage and aren't ready to talk about hearing aids, and if given the opportunity to self-fit, might be successful and might benefit from amplification at a younger age when the problem is less severe in nature. So this is an important model to know about, and we don't have time to get into the ins and outs of it. Anyway, that kind of, we're moving away from talking about self-fitting hearing aids and moving into really the second part of my talk, which is around what does audiology bring to the table that cannot be replaced by automated testing or a self-fitting hearing aid. And if you remember back to the beginning of my presentation, my second point is that counseling is a highly valued service that we oftentimes don't fully appreciate as professionals, because we're so often engaged in talking about the audiogram and about different levels of hearing aid technology. And we engage in that informational type of counseling, which is not always effective from the patient's point of view. And as I mentioned earlier, this notion of personal adjustment counseling, where you can address the internal challenges and barriers associated with hearing loss, that's really a beneficial form of counseling that many of our patients would really appreciate. So why is personal adjustment counseling critical to success? I think this is a really important question to address. And it really has to do with the fact that hearing loss is insidious in nature. And it's an invisible condition, and it really does affect all parties, all conversations. For anybody that's has a hearing loss that comes into contact with that person, they're all affected, and all conversations involving them are impacted. So just imagine, the point I want to make here is that there is a real palpable emotional consequence to not being able to hear, and oftentimes professionals gloss over this. Imagine the person who, the man on the right there, the family's enjoying a an action-packed movie or a very entertaining show, and he misses the punchline. That's a way to feel isolated from the rest of the family. There's emotional consequences associated with that. What about the people in a checkout line in a very busy store, where the person talking with the cashier can't hear them? That's embarrassing for the person, and it's also highly frustrating for those that are waiting. So those are just some examples of the emotional and social consequences of hearing loss that affect everybody that comes into contact with that person that has the hearing loss, that need to be discussed when a person comes into our office. And too often professionals don't engage or gloss over all of those feelings associated with the inability to converse. Anxiety, embarrassment, frustration, the list goes on and on. And my point is, our job is to tap into the cascading effects of hearing loss, to talk about anxiety, to talk about the avoidance that's resulting from not being able to hear, to talk about this negative self-image. And sometimes it takes years for a person to fully untangle all of those feelings associated with hearing loss. And it's not just providing somebody with a pair of devices and then saying, go and use these and you'll be successful. But as the professional, having the ability to address and untangle or unpack a lot of these feelings and emotions associated with untreated hearing loss. So what I want to do is kind of give you some tools that allow you to feel more comfortable navigating sometimes this uncharted water around emotional, social, and physical consequences of untreated hearing loss. So tools that work well in personal adjustment counseling allow you to do the things that you see listed on the slide, to explore the condition around interactive dialogue, the ability to get their communication partner, often their spouse, involved in that dialogue, to provide the patient with a sense of control, to provide them with educational and emotional support, to do what's called shared goal setting and providing them with some different options. Those are all tools that you need to have in your toolbox to allow you to practice what I call real, actionable, patient-centered care. So the tools that we're going to talk about next allow you to do the things you see listed on the slide. Get the communication partner involved. Provide the patient with a sense of control to help them establish realistic expectations. And So for over the next 15 or 20 minutes, I want to provide you with some helpful tips. Now, you could spend literally an entire 9-week course going into the details of this. So my job as a clinician is just to kind of give you, clinician to clinician, some helpful tips on how you can bring some of these things to life in your practice without investing 9 weeks or 12 weeks in a course around patient-centered care. So my first helpful tip around patient-centered care is to think of the hearing aid evaluation, or what I term the functional communication assessment. So just very briefly, a sidebar. If you're using the term hearing aid evaluation, I would change it to functional communication assessment or communication assessment, because that simple change of terminology puts the focus on the patient and takes the focus off of hearing aids. When we use the term hearing aid evaluation, it's sort of by definition has a connotation associated with it, which is the patient is automatically a hearing aid candidate. And as you all know, not every patient wants to think of themselves as a hearing aid candidate. So just a simple change in terminology from HAE to functional communication assessment puts the focus on the person, takes it off the device. And when you do that, the functional communication assessment appointment should be split into 3 phases: rapport building, information gathering, and shared decision making. Rapport building is really the thread that goes through the entire process. I have to bear with me, there's it's a holiday weekend here in the United States, as you may know, so there's a lot of activity in my neighborhood. Hopefully that'll go away quickly. But rapport building is a thread that goes through the entire process, and that's just good basic communication skills. What I want to focus on is the information gathering stage of the appointment. All the things that you need to know for you to share in the goal setting and the treatment planning of the patient. And you see that there in the middle. What do you need to do to gather as much information as you can about that person, and how do you fill up that bucket in the most efficient way possible? And I think one way to do that, and to take the focus off the audiogram, is this patient engagement strategy where you ask the patient to self-rate 3 different things: the perception of the problem, readiness to take action, and self-confidence. Getting the patient's point of view around those 3 things, in my opinion, is much more important than knowing what their degree of hearing loss is. Once you know these 3 things, you can really start the process of treatment planning. And the way that you do this is by asking what are called scaling questions. And you could go to the IDA Institute and you could gather a tremendous amount of information around how to do this using these 0 to 10 scales. And here are some examples of questions that I would weave into my presentation. How important is for you to improve the hearing right now? Question around importance. How much do you believe in your ability to use hearing aids? That's a question around self-confidence. Or a question like this: on a scale of 1 to 10, 1 being the worst, 10 being the best, how would you rate your overall hearing ability? That's I think, incredibly powerful scaling question that determines the rest of the appointment. Because if a person doesn't acknowledge or think that they have much of a problem, that becomes a very different appointment than somebody that's ready and thinks that they have a significant amount of difficulty. And in the interest of time, I'm going to point you to a study that was published in JAAA in 2009. The lead author of this study was Catherine Palmer at the University of Pittsburgh. And they asked about 800 patients during the functional communication assessment appointment that question. And they put the patient's response into one of 3 buckets. And essentially they found that if a person answered that question 8, 9, or 10, they really weren't a hearing aid candidate, even if they had a significant amount of hearing loss. That's depicted by the blue box, or by the green box. Those are the people that didn't think that they had much difficulty, even if the audiogram said otherwise. The people in the blue box, about a third of the patients were in the middle, and about 50% of that group of patients ended up buying hearing aids. And then the final group in the red box were patients that were ready to take action because they're noticing that they had a significant amount of difficulty. They answered the question between 1 and 5. And there was a better than 50% chance that they would end up purchasing hearing aids. So the teaching point here is by asking this question, you can kind of determine what the next sequence of events is going to happen. If the person answers 8, 9, or 10, it kind of becomes an educational appointment. If they answer 6 or 7, it becomes an appointment where you have to kind of show or demonstrate to the patient that they might have more trouble than they need, and they need to kind of be gently nudged into action. And if they answer the question 5 or less, then you can kind of plunge right into what some of the technological options or treatment plans could be for the patient. So I can send you the study if you ask. I'd be glad to find that and send the PDF of the study to you. The next helpful tip I wanted to share with you is how to have a better conversation or dialogue around the social and emotional impact of hearing loss. And the way that you do that, in my opinion, is through the use of validated questionnaires. These questionnaires are really a vehicle that allow you to have a deeper conversation around the social and emotional impact. So the teaching point is this. Have the patient fill out a questionnaire like this one, the Hearing Handicap Inventory. It's only 10 questions. If you want to score it, that's fine. But in a lot of ways, you can kind of ignore the score. You see at the bottom how to interpret the score. If they answer yes, it's 4 points. If they answer 2, sometimes it's 2 points. If they answer no, it's 0 points. But essentially, you can pay no attention to the score, but here is how I want you to use the questionnaire, how I'd recommend you use the questionnaire. It gives you a reason to talk about some of these emotional topics. So for example, question 1 on the HHIE is around embarrassment. How embarrassed does the person feel embarrassed when meeting new people? And say if they answer yes, the next question as a follow-up could be, I see you answered yes, Mr. Patient. Can you give me a little bit more information about where you feel embarrassed or how often you feel embarrassed? Because it's really your ability to get into the emotional impact that I think allows you to explore and have a deeper conversation that's meaningful to the patient. Take the second question on the HHIE. Does a hearing problem cause you to feel frustrated when talking to new members? If the patient answers yes or sometimes, that's an opportunity to have a deeper conversation about where they feel frustrated or how often. So I can't stress this point enough, and that is the questionnaire is really only a prop that allows you to feel comfortable exploring some of these issues around the emotional and social impact of hearing loss. It's nothing really more than that. And then once you've done that, started talking about where they're having difficulty socially, how they feel about that, frustration, embarrassed, agitated, whatever it is, then you can start the process of goal setting. And the takeaway around goal setting is to use, all of you should recognize what you see on the slide here is some version of the COSI. Remember, the COSI is an open-ended goal setting tool where you can have the patient establish up to 5 goals. My teaching point is this: pair an emotion with a social situation that's problematic for the person, and then have them rate on this scale, hardly ever, occasionally, half the time, most of the time, almost always, where they are pre-treatment, without intervention, without hearing aids. That is denoted with the C on the slide that you see here for just 2 examples. So let's take the example. The goal is to enjoy television while I'm sitting at my table, and the patient is telling you pre-treatment that they hardly ever are successful in that area. And that's kind of sort of towards the end of the appointment, after that dialogue around emotions, how the patient's self-rating. This is kind of the end of the appointment where you come up with a series of goals that pair an emotion with a situation that's giving them difficulty where they expect improvement. And you can do this in your clinic by customizing questionnaires. Here's a clinic that I work with in my position at Fuel Medical. This is a clinic here at the University of Minnesota, where we've designed a questionnaire for all 15 audiologists to use. And again, it's not so much about the score that you write down on the piece of paper. It's about taking that score and using it as a lever to have a deeper conversation with your patients, so that at the end of the appointment, you have this information around where they are pre-treatment, that's the C, where they expect to be after they've been treated, which is usually hearing aids, that's the E, and then the check mark is where the audiologist realistically is targeting improvement. So you can see, you can hopefully, by just thinking about this for a moment, you can see where there's lots of opportunities to have conversations and dialogue around the disconnect between where the patient wants to be and where the audiologist expects them to be. And the only way you can have that conversation is through a detailed information gathering process. And by doing something like this, it takes the focus, a lot of the focus at least, off of hearing aids and puts it on the individual and where they expect to be. And the hearing aids really become kind of a means to an end. One other tool that you can use in this way is what's called a decision aid. Imagine you're in your clinic and what you see on your slide is a poster that's on the wall. And it's a way to talk about different products that are available, what might be good for the patient, what may be something that's inappropriate. So you could use this and ask the patient, which of these products have you tried? Which of these products would you like to learn more about? I can tell you that this product is not appropriate for you based on what we've learned so far. So this is a way to get the person actively involved in the process and tailor the solution to what the expectations and the needs of the patient might be. So I would encourage all of you to develop your own customized decision aid that you can use as a conversation piece with your patients, and not pretend that some of these products don't exist. Even if you don't offer them in your practice, you can still talk about them and talk about maybe why they're not appropriate for the patient after the information gathering phase of the appointment. All right. So again, just in the interest of time, we'll go ahead and move to the next topic, and then we can save the questions to the end. What I wanted to talk about next is some ways that you can separate routine from complex cases. Now, the idea here is we're very quickly living in a world where people are able to self-direct their care. And I believe that some of those patients, when they come into our office, if we can gather the right kind of information, we can determine who is going to be good or successful at self-directing their own care and send them home with these over-the-counter devices, even within our own clinics. It saves us time, and it saves our patient not only time, but also potentially it saves them some money. So just to give you an idea of how inefficient we are in our own clinic, I want to give you a glimpse at some information that I gathered about a year ago in an office here in the Midwest part of the United States. This is a private practice. It gathered information in just over a couple-week period of time from 10 individuals who paid out of pocket for their hearing aids, roughly the same amount of money, and they were followed over a almost 6 month window of time to see how much office time each of the patients used. So this is giving you a glimpse at just how inefficient we are in our own clinics. what this slide tells you is that the patients came in, there were 10 patients. They came in for, all of them came in for a 1-hour hearing aid fitting. They all came in for a 1-week post fitting hearing aid check appointment. They all came in for a 1-month hearing aid check appointment. So that all 10 patients came in for 3 appointments over the first month, and that was for each patient 2 hours of clinical time. But then you'll notice that about half of the patients came in for anywhere between 1 and 4 extra visits. And in the perfect world, if all 10 patients came in for 2 hours of time over that 5+ month window, that would be 20 hours of clinical time. But what we found was that for whatever reason, half of the patients were taking an extra 10 hours of time. So what ordinarily would have been 20 hours of time allotted for those 10 patients became over 30 hours of clinical time. And so the question for the clinician or maybe the business owner is, how do we know what patients are going to take more of our time? And is it fair for the patients that took less of our time that paid the same? Is it fair to them that they're paying exactly what patients that took a lot more of our time, they're paying the same? Is it fair to the patients that paid less? So I think it's really important to think about how can we separate early on in the encounter who might take more of our clinical time and who might take less. So I just wanted to offer some thoughts on this. We need to spend a lot more time experimentally trying to figure this out. But there are some clinical levers out there that can help.
Hello. I think you can all hear me. It looks like Brian got absolutely caught. I think his internet may be fading slightly. He may realize that and come back in a second. In the meantime, I don't really see many questions coming through. And I want to ask him one. I think the message is quite clear. However, I don't envisage all audiologists behaving in exactly the same way. Brian, are you there? Nope. I think audiologists are a very rational kind of animal, and I believe that some of us will not feel very comfortable engaging in the emotional aspect that Brian was describing. But it's still extremely important to do so and engage patients in that way, especially in the advent of all these the BSHAAs and the over-the-counter hearing aids and so on and so forth. So technology and the expertise when it comes to fitting hearing aids and so on maybe not viewed as a primarily requisite from the clients or patients who come forward to see us. I'm going to check on Brian to see if he is doing okay. So just bear with me. Yes. So I've got a question here from Karen. Yeah, I'm pretty sure Brian would be happy to share his presentation. I don't know how much more he had to go, in all honesty, because I have not previewed the slides before today. I will ask them definitely at the end if he ever joins back. In the meantime, do you guys want to share any comments about what Brian has actually highlighted today at all? Any comments about that? No. Okay. Fair enough. I wanted to ask Brian about who do not, feel extremely comfortable engaging in the emotional aspect of hearing care. How would he envisage someone starting to embrace this approach? in order to actually get more comfortable with them. And I think he did tap on some various tools that are actually available out there, which most of us will probably know already. In particular, those guided tools. I think it's a very easy way to actually engage patients, customers emotionally. But I think the big question is what happens when certain emotions start coming out of those discussions that you have with the actual patient, whereby you're not either qualifying enough or comfortable enough in order to deal with those particular questions. And I love him to be able to point us out in the right direction. Secondly, I sort of wanted to actually talk a little bit on the over-the-counter and the PSAPs and what sort of what sort of approach, what sort of business model, if you like, here in BSH, as audiologists ought to go about in order to perhaps capitalize, as opposed to be frightened or uncertain about offering these kind of products, and perhaps the verification of those products in the clinic could be a way to engage with patients who are uncertain about coming forward with amplification in the form of hearing aids, but more readily able to contemplate other other products, namely a pair of headphones or a pair of wireless earbuds that may actually add them add other things to their lifestyle that hearing aids may not for some reason. They may feel more comfortable wearing a pair of wireless earbuds than they will feel wearing a pair of hearing aids. I think Brian is perhaps lost total connectivity. I'm going to check if there are any questions in here. I really don't
Can you hear me?
I can hear you, Jay. Yeah.
To answer the question about presentations, I'm sure we will be able to access his presentation. He did allow us last time. So
Yeah.
I will find out from him and possibly give it to Jamie, who will put it in the members zone with the recording of this webinar for the easy access.
So we'll be able to see all the actual slides and perhaps the ones that are missing from today's presentation.
Absolutely. And I've just sent Brian an email saying that if he can restart his system. If he does in the next 5 minutes, that's fine. Otherwise, we'll forward all the questions that we get to him. My email is education@bshaa.com. So please do feel free to send me the questions that you want to ask Brian, and I'll make an Excel sheet and forward all of them to him together.
Sure. I mean, I've got one here, which we'll certainly pass it over to him. I think it's an interesting one.
I think Karen's saying if you can narrate the last slides, I think that would be quite important because I was just getting more and more interested in his slides when he was coming towards the end, to be completely honest. So maybe either I will ask him to narrate the last slide as a separate presentation, or just narrate them within this presentation and just join the two.
Sure.
I do hope that we'll be able to sort that out.
Sure. Absolutely. I'm just going to read back to Alan. There's a slight disagree with me. Emotion is very important. Absolutely. I never said it's not important. It's the contrary. For me, it's very important. I think the question I wanted to ask is for those who do not feel comfortable engaging in the actual empathic and emotional aspect of clinical offerings that we provide, how best to actually deal with that? How do you prepare that? I don't think academia is actually currently preparing us for this very well, at least. But yeah, carry on. It says perhaps better consider showing empathy with person or even being in the same wavelength. Think back to school or uni and how one lecture went over your head. Yeah, absolutely, I agree with that. There's quite a few here. Do we know whether any audiologists in the States have started offering PSAPs, etc., as a routine solution in their portfolio? I think that's a very good one. I'm sure they are. That was from Karen.
I think the thing about that is whether the audiologists in US using PSAPs. It's a really peculiar market in US, and I'm sure that we all know about that case in Texas where somebody bought some hearing devices from Walmart, and by the virtue of the fact that they weren't registered with the professional body within Texas, the licensed audiologist actually put a case against them. And it turns out that the outcome of that case was that because the individuals who were involved in that sale were not registered with the licensure body, they weren't reprimanded. So it was an acceptable practice. So there's no mandatory requirement, or there doesn't seem to be a mandatory requirement per se, unless you're registered. So registration actually goes against you rather than to work for you in some sense. And from that perspective, whether you're selling a PSAP or you're selling a hearing device, it doesn't really matter unless you're registered with a professional body within that state. But that might be different from state to state.
Yeah, yeah, okay. So it's a really important one here. I'm just reading from Anne. I think she makes a fair comment. It sounds like he's talking about cognitive behavioral therapy in its more basic form. Maybe a standardized version could be customized specifically for hearing aid audiologists. BSHAA could produce this. Food for thought. Good comment.
Sure. I think Karen has a really good comment. And Karen, if you like, I'd switch on your mic if you want to come online. You want to share your thoughts with us?
Hi, can you hear me okay?
We can.
Yes,
Jolly good. Sorry, I know you're struggling here to keep us occupied while we're seeing if we can get Brian back. I agree, it was getting really interesting, and I think it is all the various conversations, whichever group you're in at the moment, all seem to be coming back to the difference between product and service. And so what do we do that changes the quality of the service? And I think that will be the key marker of success going forward as product becomes more and more accessible. And I think that, as I think Brian was alluding to, it might be that we already incorporate some of these self-fitting and PSAP type devices just within our normal portfolio. But it is very much more around perhaps changing the case history that we do, and we start, instead of asking all the medical stuff up front, we almost start asking about the situational impact on the hearing, and thinking of ourselves far more about how hearing loss is connected to other sensory and well-being issues, and then almost the medical bit and the audiogram bit is almost coming at the end. So I think that perhaps what we'll all start doing is thinking about the order and the way that we structure our consultations, so that we optimize the outcome. And it was just getting, as you say, interesting there, Jay, to understand how he was using some of the tools to predict those that will make decisions easily and those that won't, because that would, if you had a tool like that, that could help you then to kind of decide how you structure that session, and you might have different consultation approaches for different groups.
Absolutely, I 100% agree with that. And I think lately what I've been doing in my own appointments is I do not even talk about audiograms with many of the people that I see, not with all of them, because some of them really want to go into the nitty-gritty of the audiological bits that we're doing, particularly because as an independent, I actually charge for the first appointment. I don't do it for free of charge. So they want to sort of get the maximum out of me in that sense. But I find myself talking about more what Brian was saying and alluded to the functional bits. So I talk to them what their problem is, and I explain them in a non-audiological way the results of my audiological assessment, saying that, okay, I understand that this is coming from here and this is coming from here. So they're all connecting. So I am in a good place to offer you a solution for the problems that you told me in the first place. So this is what we're going to do. Do you agree, or do you want to add something to it? So I turn the table around and sort of ask them, how do you want me to help you? I'm an advocate for hearing. I'm not sitting here to tell you that this is what you should do, but you tell me, how would you like to use me as your advocate for your hearing solution? And that seems to be working for me. The only thing that I find is sometimes with some people, I end up spending a lot more time than I initially planned. And this is what, that's why this was getting interesting for me too.
Yes.
To see whether there were some tools where I could sort of curtail those conversations, which sometimes just get carried away, and you can't really stop them midway in order to get the rapport building that he was talking about. So I'd be very interested in listening to what he has to say next.
Yeah. And then I think I think, like you say, it is about that time management of those conversations, isn't it, really? But then also the other, it was interesting about some of the language that he was talking to us about using. And for those of us who, are disciples of Curtis and all his positive empowering language, the one thing that I get a bit stuck with is using a tool like the Hearing Handicap for starting to explore some of the social and emotional issues, but the fact that it's called the Hearing Handicap for the elderly, and I just really hate that. So I just wonder whether, as a profession, we can't start looking at some of the language of these validated questionnaires or modernizing them a little bit to fit into the kind of context that we want to operate in now.
Yeah, completely agree again.
He mentioned about the hearing and evaluation being changed to the functional communication and assessment. So that's very much in line with what you're saying.
Yeah.
Or just call it HHI. Just don't say it's hearing handicap inventory.
Yeah. Yeah.
Okay. Well, thank you very much. I think if Brian gets to see these back, we'll thank him for his time out of his busy schedule, and I'm sure he's very sorry he's missed out on the rest of the presentation. And if there are no further questions, then we'll resume here, and we'll endeavor to actually get back to people who have posted some questions about the rest of the presentation, basically, and we'll try and get back to you guys via the website.
Brilliant. Thanks, Karen, for your contribution as well. That was very welcome.
Thanks, Karen.
Thank you.
Thanks.
Bye. Bye.
Thanks, everybody. Bye.